Welcome back. Today, we're diving deep into the microscopic world of blood disorders. We're going to explore a really fascinating family of diseases that completely rewrites the rules of how your body manufactures its most vital fluid. So get ready, because we're heading straight to the source of production, your bone marrow.
I want you to keep this question in the back of your mind as we go through today's explainer. What actually happens when your body's blood cell factory just completely loses its off switch? Imagine a super efficient, strictly regulated factory. Then, out of nowhere, the manager goes rogue, ignores all the stop signals, and just leaves the assembly line running at absolute maximum speed. Well, that is exactly what's happening inside the bones of patients with these specific blood disorders.
Okay, let's dive into this. Here's our roadmap for today. We'll cover the rogue factory, the saboteur, polycythemia vera, essential thrombocythemia, primary myelofibrosis, and wrap it all up with managing chaos.
Part 1. The bone marrow goes rogue.
Before we can truly appreciate the chaos of these diseases, we need to establish exactly what breaks down in the first place. The disorders we're looking at are called myeloproliferative neoplasms, or MPNs. Now, the absolutely crucial word here is clonal. This isn't just your body reacting to an infection and making more cells. No, this is a foundational glitch in the very blueprint of a single hematopoietic stem cell. That one broken cell clones itself, completely takes over the marrow, and relentlessly overproduces mature myeloid cells. To picture this, think of the multipotential hematopoietic stem cell, the one at the very top of the lineage tree, as our factory manager. In a healthy body, it's a great boss. It carefully delegates production down the branches. It tells the common myeloid progenitor to synthesize more erythrocytes if you need oxygen, or signals the megakaryocyte to shed some platelets. But in an MPN, that top-level manager is corrupted. It's basically just constantly shouting, "Produce, produce, produce," down one or more of these branches.
Let's move to part 2, the JAK2 mutation saboteur.
So, what exactly corrupts the manager? What's the molecular error forcing all this overproduction? Well, what's really interesting here is this concept of one mutation, many phenotypes. In the vast majority of classical MPNs, the culprit is literally a single acquired genetic error on the short arm of chromosome 9. It's a tweak in a gene called Janus kinase 2, or JAK2 for short. And the wild part? Even though it's the exact same mutation, it can manifest in 3 completely distinct and very serious clinical conditions.
Just look at the sheer dominance of this specific mutation, JAK2V617F. It is heavily anchored to polycythemia vera, showing up in an astounding 95% of cases. Meanwhile, it's present in about 50 to 60% of both essential thrombocythemia and primary myelofibrosis cases. Basically, if you're investigating an MPN, the JAK mutation is the absolute first suspect you look for.
But what does this mutation actually do? Scientifically, it leads to constitutive tyrosine phosphorylation activity, which is a mouthful, I know. But it's easier to think of it like a stuck accelerator pedal on a car. Normally, a cell needs growth factors, like erythropoietin, to step on the gas and start producing. The JAK2 mutation entirely bypasses this. It forces the cell into the state of hypersensitivity, making production completely independent of those normal biological signals. The engine is just endlessly roaring.
All right, Section 3, polycythemia vera, or red cell overload.
Let's dive into our first major phenotype, where that stuck accelerator forces the factory to overproduce the red cell line. This is polycythemia vera. Now, we have to make a really vital clinical distinction here. True PV is an absolute polycythemia. That means the actual mass and volume of red blood cells has increased to over 125% of what's normal for that person. This is very different from relative or pseudo-polycythemia. In a relative case, the red cell mass is actually totally normal, but the patient is severely dehydrated. That means there's less plasma, making the blood just appear artificially concentrated. Now, because the red cell mass in true PV is so incredibly high, the blood gets thick, really thick. We call this hyperviscosity. Patients deal with headaches, blurred vision, and they often have a visibly red, plethoric appearance. But here's one of the most uniquely memorable symptoms: severe generalized itching, called pruritus, specifically right after a hot bath or shower. And it's intense. It's driven by the massive hypermetabolism and the release of chemical factors from all those excess cells. Next up, Section 4, essential thrombocythemia, or platelet overdrive. Shifting our focus over to the megakaryocyte branch of our factory, we see platelets being churned out recklessly. We are talking 450 times 10 to the 9th per liter. A sustained, unexplained platelet count above this exact diagnostic threshold is the defining hallmark of essential thrombocythemia, or ET. But, and this is a big but, clinicians have to rule out every other reactive cause for high platelets first. Things like iron deficiency or inflammation have to be off the table before officially confirming an ET diagnosis.
And this brilliantly illustrates the problem. Under the microscope, platelet overdrive is unmistakable. A peripheral smear reveals large, hypogranular, clumped platelets just completely crowding the bloodstream. And if you look directly inside the factory via a bone marrow biopsy, you'll find the culprits: giant megakaryocytes with massively hyperlobulated nuclei. They are hyperplastic, oversized, and severely overactive.
This sets up a truly fascinating and dangerous clinical paradox for ET patients. You'd logically think that having too many platelets would strictly mean dangerous blood clots, right? A thrombotic tendency. And yes, patients do face high risks of arterial and venous clots, plus this intense burning pain in the hands and feet called erythromalgia. But ironically, when the platelet count gets overwhelmingly high, say over 1 million, the body's clotting factors get depleted. So patients actually develop a hemorrhagic tendency. They suffer from easy bruising and gastrointestinal bleeding. It's wild. Their blood is simultaneously prone to inappropriate clotting and inappropriate bleeding.
Which brings us to Section 5, primary myelofibrosis, or scarred marrow.
We are now transitioning to the final classic MPN, and you can really think of this as the tragic endpoint where our overworked rogue factory finally just burns itself out. In primary myelofibrosis, the bone marrow fills up with reactive scar tissue. Because the primary factory is shut down by this fibrosis, the body frantically tries to make blood elsewhere, usually the spleen and liver, which causes massive splenomegaly. When doctors try to draw marrow, they hit a dry tap. The blood cells that do manage to escape into the bloodstream get squeezed and deformed through the scar tissue, resulting in these misshapen teardrop cells. Tragically, this condition carries a 10 to 20% risk of transforming into acute myeloid leukemia. So the crucial point is seeing the actual destruction, the dense, dark, web-like fibers visible on a reticulin stain of the bone marrow are physical scars. They are literally choking out normal blood production. It's just a stark, sobering representation of a marrow environment that has been totally destroyed by this fibrotic reaction. Finally, Section 6, Managing Chaos and Future Outlook. So now that we understand the deep pathophysiology of all this, how do modern clinicians attempt to control this rogue factory? Well, the management goals are pretty sobering. We are dealing with chronic conditions here. The primary objectives are simply to alleviate the patient's symptoms and fiercely prevent those life-threatening thrombotic or hemorrhagic complications. We have to acknowledge two really hard truths. Outside of a highly risky stem cell transplant, there is no curative treatment. And unfortunately, standard medical therapy doesn't prevent the disease from eventually transforming into acute leukemia or advanced myelofibrosis. Right now, we're managing the chaos, not curing it.
But we do have a therapeutic toolbox to help manage that chaos. For polycythemia vera, clinicians use venesection to physically lower the red cell volume. They'll use low-dose aspirin to inhibit platelet aggregation and prevent clots. For high-risk patients, a drug called hydroxyurea acts as a cytoreductive agent to chemically bring those cell counts down. And because we now know about the precise molecular saboteur, we have targeted therapies. Drugs like ruxolitinib can directly inhibit that deregulated JAK-STAT pathway we talked about earlier.
We've mapped out the normal factory, identified the JAK2 saboteur, and witnessed the devastating results of overproduction and scarring. But with the advent of direct pathway inhibitors like ruxolitinib, we're really entering a new era. So I leave you with this. As we continue to unlock the specific genetic pathways driving these complex disorders, will MPNs soon transition from chaotic conditions that we merely manage to ones that we can definitively cure? That is the bleeding edge of hematology and is a future absolutely worth keeping an eye on. Thanks for joining me today, and keep learning.